Thank you so much, Dr. Hassan. Professor Hassan, you are my professor, you are my mentor, you are everything that made me what I am now. Very, very nice presentation. Thank you, Dr. Ashraf, for the nice presentation, and thank you for being here with you today in this very eminent meeting. We'll talk about the diagnosis of PCOS and what are the different phenotypes. PCOS was first described by Steen and Leventhal, which was back in 1935. And the syndrome was first described in 7 women who had combination of all the full spectrum of the disease. These ladies suffered from obesity, hirsutism, amenorrhea, bilateral enlarged polycystic ovaries. However, in the early 1990s, the National Institute of Health first proposed a diagnostic criteria for PCOS. It defined PCOS as a combination of oligo or anovulation in addition to androgen excess, after rolling out other causes for anovulatory infertility and for hyperandrogenism. However, as we see, the polycystic ovarian morphology was not one of their criteria. Till in 2003, the Rotterdam criteria, the most famous and the most successful criteria, came out, and the diagnosis depending on finding 2 out of 3, which is hyperandrogenism, either clinical or biochemical, in addition to menstrual irregularities, as they defined it as less than 9 cycles per year, or cycle frequency after more than 35 days, in addition to polycystic ovarian ultrasound morphology, which was diagnosed by them by that time as more than 12 antral follicles per ovary, or ovarian volume more than 10 centimeter cubic. However, we will base most of our discussion today on the international evidence-based guidelines that was published a couple of years ago. Definitely, it's very difficult to talk about guidelines after the person who developed it, Professor Norman, but we'll only highlight parts that we will want to share with you. First of all, the definition of menstrual irregularity. Menstrual irregularity is normal in the first year after menarche. So after menarche by 1 year, in the first year, there is nothing called menstrual irregularity, it's physiologic. After the first year, if the cycle more than 90 days, this is menstrual irregularity. Primary amenorrhea by the age of 15 or 3 years post-LARC is considered as irregularity. But after 3 years of menarche till perimenopause, cycles are supposed to be regular. And irregular cycles can be defined as cycles which is coming after less than 21 days, which is polymenorrhea, or after more than 35 days, oligomenorrhea, or less than 8 cycles per year. Regarding biochemical hyperandrogenism, it's always difficult what to measure and when to measure. It is present either clinical or biochemical in 60 to up to 100% of your patients according to the defining criteria you are using. When to measure, it's not any time of the cycle. Preferably, it should be measured early in the follicular phase because testosterone secretion may increase in the mid-cycle. Morning samples are more accurate due to the diurnal variation. What to measure? Everybody is measuring testosterone, but measuring total testosterone is not that accurate. You need to measure the free testosterone, the active form. If you are to measure total testosterone, you will only diagnose 20 to 30% of your patients as having biochemical hyperandrogenism, but measuring free testosterone, especially using the free androgen index, you can find almost 60% of your patients as having hyperandrogenism. So according to the recommendation, calculated free testosterone or free androgen index is the best diagnostic criteria. You really need to measure androstenedione or DHEA-S because usually it will be normal. In cases of total or free testosterone which are not elevated, maybe you can find more information by measuring these hormones. Reliable assessment of biochemical hyperandrogenism is not possible on patients on hormonal contraception. And a lot of these patients are on hormonal contraception, either for the sake of contraception or for the sake of regulating their cycle. Moreover, if the lady is on hormonal contraception, you need to leave a withdrawal period of at least 3 months before assessing her androgens. Assessment of biochemical hyperandrogenism is useful in cases with no signs of clinical hyperandrogenism, because if the case has clinical hyperandrogenism, you don't need to have a biochemical proof. Second, everybody is always asking about the reference ranges and why did the guidelines didn't put any reference ranges. Reference ranges vary from different laboratories, and according to the guideline, stick to the reference range sent you by the lab. It's also very important to say, markedly elevated androgens are rarely due to PCOS. Markedly elevated androgens usually due to other causes, and definitely neoplasia should be excluded in these cases. Regarding the clinical hyperandrogenism, we have in these cases mild to moderate clinical hyperandrogenism, not severe hyperandrogenism, which is named viralization. Viralization is very rare in PCOS. Actually, it's not present in PCOS. The most common symptom and sign is hirsutism, which is recognizable male pattern terminal hair. In the definition of terminal hair is a pigmented hair that can grow up to more than 5 millimeters if not removed. The only approved way to assess is the modified Ferman-Galloway scale, and there are 9 areas: upper lip, chin, neck, upper chest, upper abdomen, lower abdomen, thigh, upper back, lower back, and upper arms. And every part of these areas will take a score from 0, which is no terminal hair at all, till 4, which is well-developed male pattern. These are the areas, the 9 areas, and scoring, by adding score in these areas, you reach the Ferman-Galloway score. But you should know that we are Middle Eastern and we have a higher cutoff scores due to the ethnic variation. Acne is common in adolescent girls, and it's difficult to depend on acne in adolescent girls. Usually, if the case has more than 10 facial lesions, you can depend on it. To diagnose clinical hyperandrogenism, we need to have a comprehensive clinical and a comprehensive history and examination. And we should know the psychological impact, especially in adolescents, is very important in these patients, so you should consider. Regarding the cutoff levels, the range is from 4 to 6 for the Ferman-Galloway scale, and we as in the Middle East, we will take 6. So the cutoff level will be 6 in our region. The ultrasound was not present in the previous classifications, but it was added by the Rotterdam classification. And in the original Rotterdam, as we mentioned, they said 12 or more follicles. But now, due to the advances in the ultrasound technology, we are talking about 20 follicles per ovary, measuring from 2 to 9 millimeters. But definitely, you should use the transvaginal ultrasound. So if you have a version and you are using the abdominal ultrasound, you will depend on the ovarian volume, not on the counting the follicles. And as it was mentioned previously by Professor Hassan Ali and Professor Norman, you can never depend on the ultrasound in the first 8 years after menarche. So 8 gynecologic years mean 8 years after menarche, at least, to depend on the ultrasound. Most of the clinicians will get versions 14, 15, 16 years old, asking them to come with a full bladder to do an ultrasound, and this ultrasound actually is useless as a criteria for diagnosing PCOS. So as we said, endovaginal ultrasound, more than 20 follicles, and if you will depend on the abdominal ultrasound, you will use the ovarian volume. Another point as the cascade or the pathway that was mentioned by Professor Noe, if you have irregular menstruation and the hyperandrogenism, you don't need an ultrasound to reach the diagnosis of PCOS. You're already having 2 important criteria. You don't need the 3rd criteria. Okay, you can do ultrasound for any other causes, to exclude any other pathologies, to plan your management, but you don't need it to diagnose the condition. Regarding anti-Mullerian hormone, as was said previously, anti-Mullerian hormone levels are definitely higher in PCOS patients. Besides, anti-Mullerian hormone can aid in cases where ultrasound is difficult, as in virgins or obese patients. However, there are almost 30 studies that was done to see the diagnostic accuracy of AMH for PCOS, but unfortunately, no cutoff levels could be reached due to the heterogeneity in the AMH assays. So as sometimes we suffer in our country here, it's not because our labs are bad, but worldwide, there is no consensus on the assays, on the cutoff levels, but according to the guidelines, it is coming. So till now, you can't use AMH to diagnose PCOS, but they are predicting that it is coming, as it's said in 1.5.2. There is an emerging evidence that with improvement, standardization of assays and establishing cutoff levels or threshold based on large-scale studies, so it is coming, but not now. Also, we are not doing AMH to diagnose PCOS, but definitely you can do AMH to plan your treatment. You can do AMH to plan your dosage. It's very important, not to diagnose, but to plan your treatment. So please do it, especially for cases prepared for ICSI, as we'll hear after that. Ethnic variation. There are a lot of ethnic variation between subgroups. For example, Caucasians have a very mild phenotype, higher BMI. We in the Middle East, there is severe hirsutism, and also in the Mediterranean women. In East Asia, there is high diabetes, whatever. So there is ethnic variation. If you are working in an area with different variations, like in the Gulf area, you should know all this. In the perimenopause period, you usually depend on the history of long-term of oligomenorrhea and hyperandrogenism in your diagnosis. Usually, you will not find PCO morphology in the perimenopause, but definitely if it's present, it will confirm your diagnosis. So, the diagnostic criteria according to different societies as we compared, first the NIH, it didn't mention anything about ovarian morphology. Then as we said, the Rotterdam said 2 out of 3, which is the most common used criteria now. The Androgen Access Society in 2006 said 1 or 2 plus. So it said it should have hyperandrogenism, clinical or biochemical, plus either oligo or anovulation or the ovarian morphology. So if we see it's like these circles, the NIH was the most strict criteria, and the androgen insensitivity was in between, and Rotterdam was the loose criteria. So the Rotterdam included more patients and identified more patients. All these societies said that you have to exclude other causes, especially the thyroid disease by using at least serum TSH, prolactin, serum prolactin, and the non-classical or the adult type congenital adrenal hyperplasia by using the early morning 17-hydroxyprogesterone. So what are the phenotypes? According to different combinations of the presence or absence of the criteria of Rotterdam's criteria, we have 4 phenotypes. The first phenotype, phenotype A, is the full-blown picture of PCOS, oligoanovulation, hyperandrogenism, besides the ultrasound morphology. This is the classical. Most of the cases are from type A, and this is most severe. Then type B, all except the ultrasound. Type C, the hyperandrogenism and PCOM is the morphology without the menstrual irregularity, while in type D, this is the only type without hyperandrogenism. Type D is oligoanovulation and PCOM. So these are the different phenotypes. And as we see, according to different societies, of course, all of them are PCOS according to the ISHRI SRM Rotterdam criteria. But according to the NIH criteria, only type A and B are considered as PCOS. And according to the Androgen Society, it is type A, B, C, but D, because there is no hyperandrogenism, it is not considered PCOS. Regarding comparison between different phenotypes, as we see according to this study in human reproduction, more than half of the cases are phenotype A and quarter phenotype D, and the rest is divided between B and C. It was found that phenotype A is characterized by higher AMH levels, higher BMI, higher LH-FSH ratio, and higher serum testosterone. Also, all but type D has increased incidence of metabolic syndrome. Regarding the outcome in IVF cycles, according to different subtypes, it was found that type A had higher gonadotrophin requirements, but will yield lower oocytes. All have the same clinical pregnancy rate. Clinical pregnancy rate is the same, but there are just few differences. Type A will need higher doses, and the outcome of retrieved oocytes will be less. All types A, B, C, which are all types without hyperandrogenism, was found to have significantly higher abortion rate. So the hyperandrogenism probably can explain this abortion rate, and maybe the high androgens will disturb the oocyte and embryo development. Thank you very much for Professor Hassan Ali, Professor Ashraf, and for the IFRI, and I'm ready to answer any questions.
Thank you very much for an excellent presentation. You surprised me, as always, with your last 3 slides. So you've mentioned that the phenotypes have clinical relevance, apart from their distribution. You've said that some types have resistant to gonadotropins, sometimes have more abortions, and yes, you characterize that type A has LH-FSH ratio disturbance, which we found in our studies to be present in 30%. I think, Sherif, this is very, very, very important. And if you can take of your time, because after this, you will not be in the same hot area, and just explain them to us on the IFRI PCOS group slowly, and we can dig on studies. And I think we can come up with a nice study, because if this surprises me, this surprises a lot of people also.
Definitely.
It's very impressive, these last 3 slides.
Thank you very much. Thank you. And actually,
after thanking me, you will promise me to do this during the next 3 days on the group, right?
Okay, sure, definitely.
Okay, definitely. Please.
And actually, there are very few studies comparing the IGZI outcome in different phenotypes of PCO. So this is a very good topic.
Excellent.
To be, yes, I only, just a couple of studies comparing the outcome, and it was more than 10 years ago, the outcome according to different phenotypes. So maybe this is a hot topic for research that can be done by the PCOS interest group of the IFRI.
Thank you.
Thank you.
Polycystic ovarian morphology must be unilateral or bilateral? Dr. Sherif, please.
Yes. Polycystic ovarian morphology, we are talking about at least 20 follicles per ovary. So it should be bilateral.
Okay, another question in virgin. I think this will be for Professor Abu-Bakr. Next slide. Another one about the different types of PCOS. Dr. Amona Gabri is asking, is there is a difference in the management of each type of PCOS?
No, there is no difference. Up till now, there is no difference in management. The problem is in the phenotype itself. The problem is how to diagnose. But you have different findings. For example, the BMI is higher in phenotype 1. AMH is higher, so probably you will have a more metabolic syndrome. Subtypes with hyperandrogenemia, you should correct before start treatment, as hyperandrogenemia may lead to increase in the abortion rate. Phenotype 1 will also may need adjustment of the dose of gonadotrophins in cases prepared for IGZI. So there are no solid recommendations, but it's just like fine-tuning of your practice.
Dr. Ashraf, if you allow me, I have a comment for this.
Yes, please. Professor
for type C, which is ovulatory polycystic ovary syndrome, it is not recommended to do laparoscopic ovarian drilling.
So another one about the, I think, Dr. Sherif, you can repeat, because one of our colleagues is asking, what are the investigations to diagnose PCOS? Are they FSH, LH, free testosterone, and AMH? Please, can you confirm the hormonal important investigation with priorities for PCOS again for the candidates?
First of all, FSH-LH is not anymore a diagnostic way to diagnose PCOS. So
yes.
no need to do FSH-LH to diagnose the syndrome. It's not present in any of the diagnostic criteria present now. Let's take it like a cascade. First of all, if you have oligo or anovulation or oligomenorrhea, in addition to hirsutism, you don't need to do any hormonal profile. You are just doing hormonal profile to exclude other causes of hyperandrogenism or other causes of oligoovulation. So you will do TSH and prolactin to exclude other causes of disturbed menstruation. So if you have the complaint of irregular mens in addition to hirsutism, this is enough. Okay, this is number one. If you have only one criteria, you need to have another criteria. So you need to do an ultrasound. If you have an ultrasound in addition to oligo or anovulation, this is enough for diagnosis too. You don't do AMH to diagnose the syndrome. You do AMH to help in the management. Okay?
Okay.
Here?
And what is the cutoff limit, Dr. Sherif, for the AMH you use?
No cutoff limit.
Suggested?
Suggested usually are talking about above 4.5, maybe above 5, but there is no cutoff limit in the guidelines.
Okay, the next few questions.
Actually, yes. It is a spectrum. As the AMH increases, there is higher incidence of ovarian hyperestimulation syndrome. You need to do more prophylactic measures. So it is a spectrum. It is not an absolute figure, but also it is reported, and from our practice, that cases with very high AMH above 7 and 8, they usually need very, very, very accurate dosage, because they are not going to respond to lower dosage, and you have to increase the dose, and maybe you have to add HMG, not only FSH. So the cases with extremely high AMH needs extreme caution, and expertise is a must to stimulate these cases.